Welcome to AETCM, the emergency medicine channel. Shall I start?
Yes.
Sir, a 65-year-old female patient presented with complaints of sudden painless loss of vision in left eye with a sparing of central vision around 3 hours prior to the presentation to the ED. On initial 10-second assessment, airway is patent.
You mean tubular vision,
sparing of the central vision. Airway is patent. Breathing saturation is 99% in room air. Respiratory rate is 18 per minute. Airway entry is bilaterally equal. Circulation pulse rate is 88 per minute. BP 160/100 and all peripheral pulses palpable. Disability GCS is 15/15. GRBs is 168 milligram per DL. Exposure is febrile. No known allergies.
Is it a hypertensive patient?
Now, in case of rheumatic heart disease with severe MS and moderate AR, dyslipidemia, atrial fibrillation on tabacitron, and presented with complaints of sudden painless loss of vision of left eye with a sparing of central vision around 3 hours prior to presentation while she was watching television. There is no associated eye pain, trauma, redness or burning sensation, itching or photophobia, no history of trauma, no history of floaters or flashing lights. There is
What is the importance of these type of symptoms? Floaters, flashing light.
Floaters and flashing lights in case of retinal detachment or retinal hemorrhage, and also in case of cataract with
Common thing. Common disease. Migraine. Migraine is one of the common disease where you get flashes of light, spotters, sudden loss of vision, transient loss of vision, then regains the vision.
And no preceding visual aura or transient loss of vision loss, and no symptoms in the right eye, no history of recent trauma or surgery, and no history of headache, jaw claudication or scalp tenderness, no history of fever,
headache,
weight loss,
jaw claudication, visual loss,
giant cell arthritis,
What is the age group?
Elderly, more than 60 years. And no history of proximal muscle weakness, no neurological symptoms, slurred speech, limb weakness or imbalance or altered sensorium, no history of seizure or LOC, no history of chest pain or palpitation or shortness of breath, and no history of recurrent miscarriages to rule out the hypercoagulable states. And on examination, there is no carotid bruit, no pallor, icterus, cyanosis or clubbing, CVS, S1 S2 heard and a diastolic murmur present, CNS no.
You told atrial fibrillation. S1, S2 heard. Normally.
Sir, atrial fibrillation with controlled ventricular rate in ECG.
What will be the S1, character of S1, atrial fibrillation? Soft. So basic MBBS knowledge. What will happen to S1 in atrial fibrillation? What will happen? It's a very simple, straightforward question all MBBS students should know. S1 will be varying because each pumping is different. Each quantity of blood pumped out is different in each beat. So S1 has to vary.
And
control rate means how much was the rate?
Patient has 78.
78.
CNS, no focal neurological deficit, respiratory, air entry,
Visual loss is a
bilateral,
focal neurological deficit.
visual acuity is light perception in the peripheral field is decreased with clear vision in the central field. Pupil, relative efferent pupillary defect present, and when fundoscopy was done, pale retina.
What is the importance of pupil in visual loss?
We can check for the according to the pupil, we can identify which level of involvement, whether it is involved in case of retina, optic nerve or behind, or whether it is involved in media like cornea, vitreous.
What is the nucleus which controls the pupillary reflex?
Wernicke's.
Nucleus.
Oculum.
We are presenting a case of visual loss. That's why I'm asking. Pupil is very important. What is Edinger-Westphal? So that controls your pupillary reflex. That is applied by anterior or middle or anterior middle. I don't remember. So anterior cerebral artery. Okay. Whereas your center for vision is, where is the vision center?
Occipital
Occipital.
cortex.
That is applied by
both
posterior and some middle.
cerebral
Okay.
artery.
So the posterior circulation strokes, like you might have read about press, all these things. So pupil will be spared. Okay. So central blindness, pupil will be spared. Okay. Whereas peripheral apparatus block or lesion, pupil will be involved. So that's why pupillary reflex is very important in a bilateral visual loss condition. Here, what is happening to the pupillary reflex?
Pupillary reflex is relative. Afferent pupillary defect is there, but pupillary reflex is
present. Because he is having tubular vision. He is having some vision, not completely lost.
Yes. And in adjuncts to the primary survey, we took one ECG which shows AF with fast ventricular rate, and we also
told the control ventricular rate.
Control ventricular rate, and in echo.
How do you differentiate complete heart block with atrial fibrillation and atrial fibrillation with controlled?
Regular PV. If there is complete heart block, regular PVS will be there.
Regular?
P.
P.
AF will be.
What are you talking? P or QRS? Complete heart block with atrial fibrillation. You are telling PP interval. Where is the P in atrial fibrillation? Is there a P wave? Is there a P wave in atrial fibrillation? So they are telling PP interval is normal. What they wanted to tell is RR interval is okay. So RR interval will be regular in complete heart block. RR interval will be still varying in controlled ventricular rate. That is very important, because when you have a controlled ventricular rate in atrial fibrillation, first thing you have to check is whether the rate is coming regular or not. If it is irregular, then it's okay. It's accepted.
And we also done an echo to rule out the embolic source. There is no elder clot, and suggested carotid Doppler to check for any atherosclerotic plaques in the carotid. And
what is the age of the patient?
60.
60. Diabetic?
No, not diabetic.
Not a diabetic.
Dyslipidemia is there. And also check for fasting lipid profile, total cholesterol, LDL, and HbA1c.
So
and also
what
check
time you check the cholesterol level?
fasting lipid profile.
Okay.
Fasting. And HbA1c also done, and ESR and CRP to rule out arthritis in the elderly. And from the
CRP or ESR?
ESR and both CRP.
Which is more significant?
ESR.
ESR is very significant in chronic inflammation, whereas CRP is
Acute.
important for acute. So in this temporal arthritis, ESR will be very, very high. Okay, whereas CRP may be high, sometimes it may be normal also.
And from we also done an ophthalmology consultation. They suggested OCT, optical coherence tomography, and fluorescent angiography. And from the ophthalmology side, during fundoscopy, they found pale retina with a cherry red spot. So they managed it as an central retinal artery occlusion.
Okay.
Before that, we took an MRI brain stroke protocol since the patient presented within the window period, and we rule out acute stroke. And from the ophthalmology.
Is it an acute stroke?
Sir,
it is an acute stroke.
CROA can be considered as an acute stroke.
Okay.
But cerebral clot we excluded by doing MRI brain stroke protocol, and managed within 4 to 6 hours. They done an ocular massage to dislodge the emboli, and also the anterior chamber paracentesis was done. And they also done inhalation of carbogen, 95% O2 plus 5% CO2.
Okay.
And IV acetazolamide to decrease the intraocular pressure.
Okay.
And also there is trials to study the efficacy of antiplatelet therapy, and statin optimization and diabetic control and BP control is important for this. And we also done neuro and cardiology consultation for the risk evaluation. And
what risk evaluation you are talking?
So the causes of for any further risk for stroke.
How do you rule out that?
In case of if there is any cardioembolic stroke possibility, there is from, and also
Is this
any
patient is on
patients.
warfarin?
Azithromycin.
Azithromycin. Okay, what was the INR?
INR is 2.6.
2.6. Okay.
And while we're discussing the different causes of painless loss of vision, One causes central retinal artery occlusion and central retinal vein occlusion, and also the acute ischemic optic neuropathy, cataract, vitreous hemorrhage, and retinal detachment. And these all
Optic
are
neuritis is painful or painless?
optic neuritis is painful.
So that doesn't come here as a differential diagnosis.
Differential. And also the CMV retinitis and a functional visual loss. In case
CMV retinitis is seen in which type of patients?
of immunocompromised patients, HIV patients. And also the painful loss of vision is acute angle closure glaucoma, optic neuritis, uveitis, migraine headache, and giant cell arteritis. And in CRO,
Giant cell arteritis is unilateral or bilateral?
bilateral.
Giant cell arteritis mostly it is unilateral, mostly, but
Mostly.
it can occur
Can occur
bilateral also.
And CRO, the causes
I'm
are
not telling arthritis. Visual loss is unilateral.
central retinal artery occlusion causes are cardiac or carotid emboli or retinal artery thrombosis, giant cell arteritis or vasculitis or sickle cell disease, trauma or vasospasm, and the patient present with sudden profound painless monocular loss of vision and often preceded by the episodes of amaurosis fugax.
Amaurosis fugax. What is it?
Transient loss of vision.
It's a pre-stroke condition.
Pre-stroke condition. And in CR, central retinal vein occlusion, there will be thrombosis of central retinal vein, and there will be retinal venous stasis and edema and hemorrhage. And the risk factors like diabetes, hypertension, dyslipidemia, and hypercoagulable states, and vasculitis. And presentation is also like variable, like blurring to rapid painless loss of monocular vision. And in fundoscopy, in case of CRA, we see pale retina with a cherry red spot, but in case of central retinal vein occlusion, there will be optic disc edema and diffuse retinal hemorrhages in all quadrants, known as blood and thunder fundus. And in retinal
Why this
detachment,
patient is having a middle, like tubular vision?
In
Normally they lose full vision.
yes, so in macula is also supplied by the cilioretinal artery, which is a separate circulation.
Okay.
That's why the macula sparing is
Sparing has happened.
And retinal detachment and flashing, there will be flashing lights and floaters, and symptoms will be flashing light, floaters, and dark veil or curtain in front of the vision. And the diagnosis, there will be diagnosed by dilated indirect ophthalmoscopy evaluation by the ophthalmologist. In case of giant cell arteritis, it is a systemic vasculitis, so that it seen in more than 50 years of age with a history of polymyalgia rheumatica, and symptoms will
What
be
is
headache.
polymyalgia rheumatica?
There will be painful joints and muscles with proximal muscle.
Polymyalgia rheumatica. Joints are not involved.
Muscle involvement
Muscles are involved.
with proximal muscle weakness.
Continue.
And the symptoms will be headache, jaw claudication, myalgia, and fatigue. And in case of giant cell arteritis, the treatment is high dose corticosteroids. That is, if there is no visual symptoms, we can give prednisolone 60 mg OD until further follow up with the ophthalmology. And if there is
What is the
visual
dose of oral steroid in acute vasculitic conditions? 60 milligram is a general dose. Suppose you get a 40 kilo male. What is the dose? You get a 100 kilo male, or male or female. What is the difference in dose? How do you calculate? You told 60, that is okay.
1 mg per kg.
1 mg per kg. 1 to 2 mg per kg body weight is the dose, ideal dose in acute condition. 1 mg is a reasonably good dose.
If there is visual symptoms, high dose IV methylprednisolone 500 to 1000 mg per day for 3 days. And in
What are the alternatives for that? Hydrocortisone is not an alternative. This is called as pulse therapy.
Pulse.
So 1 gram methylprednisolone you give. That is very costly. What is the other cheaper alternative? Dexamethasone. Dexamethasone 40 to 60 milligram IV is equivalent to 1000 milligram of methylprednisolone. That cost is very huge. Compare the cost, it will be very, there is a huge difference. What is the basic difference between hydrocortisone and dexamethasone? Is there a difference?
So when
Fluid retention is more in
hydrocortisone.
hydrocortisone. What else? Brain penetration. Meninges penetration is which is better?
Dexamethasone.
Brain penetration, dexamethasone is better than methylprednisolone.
And in case of long-term management, we can give chronic anticoagulation, and in case of high-grade carotid disease, we can run carotid endarterectomy and antiplatelet therapy and atherosclerosis risk factor modification.
Acutely, how did you manage this case?
First of all, we can give ocular massage with basically to reduce the intraocular pressure by ocular massage, and also by anterior chamber paracentesis.
Okay.
We can give carbogen therapy can be given.
Okay. What happened to the vision of this patient?
After the initial management, the vision improved from the counting fingers to perception of light to counting fingers.
Okay.
Later, the patient get admitted
Okay.
under the general medicine department.
What is visual evoked potential? VEP.
That can be
What is it? Visual evoked potential. Where will you do that? We have done recently one patient, that HIV patient who was admitted here with visual loss. Huh? She comes here for, huh? It is for nerve. Nerve. So we'll know exactly where is the lesion in the nerve, whether it is in the optic nerve or optic chiasma or in the brainstem area. So exactly it will pick up where is the lesion. Okay. That patient had optic neuritis. We'll know where is the lesion. Okay. Either vasculitis or neuritis. Vasculitis, like you told, this patient we have diagnosed. Okay. VEP can be done if artery or vein is not involved. Then we have to do whether the nerve is involved. Okay. What happened to the patient afterwards? Improved?
admitted in the general medicine department for observation.
Okay.
Just recently came.
Okay. Thank you.